when I retired, I thought I would create a change a nonprofit that I actually started, if you can believe, in 2005. And, then I had kids in my house, parents. I invited creative artists. We did different workshops, but it was very low key, low budget. Um, until I retired, and then I could really give a lot to it as Neil is able to give more now to ChildKind. It's hard to do all of it at once. And I wanted to be a supplement to all the growing great pediatric pain programs that are out there. So the intent was not to diagnose, and treat kids with chronic pain, but it was going to be kind of I'm very pictorial, call it the filling of the hamburger, the clinic visits or the buns. And we're sort of what you do while you're waiting for in between your clinic visits. So I thought I would talk about why I named it creative healing and kind of what do we do? What does that mean? Next slide, Meredith. Next slide. Are we frozen?
Yeah, I don't know. It looks like the next slide to me. So that seemed like that's what happened with you as well, Bill.
It just says creative healing. It's the first slide.
That is so strange. Okay.
Do you want me to?
I mean, I can go back and then forward again, see if that makes a difference.
Yeah, try it. Because you went from one set
Yeah.
to the other.
Yeah, I mean, I'm
Yeah,
shifting through slides and
everybody's
it's,
seen the first slide.
I don't know why that would be,
And I can,
because I am seeing the next slide. Do you want me to, you could
I
share your
I
screen?
only see, and I think somebody else said they only see the first slide.
Maybe Lonnie could do it from her screen. Are you able to do that, Lonnie?
Yeah, why
Yeah,
don't I make you a, yeah, let's do that.
figure out how to do that. Make up my slides up.
Apologies, everyone.
My slides. Let me get my slides. Sorry, I'll talk faster. Okay. ChildKind. Okay. All right. I want to give me
You know what? Yep. You do
how,
have host capability
what?
now.
All right. Next slide. Oops. I don't want to do that. How do
I might be able, I saw something on my computer that I might be able to run it better now if you want me to try one more thing.
okay.
Go ahead, Meredith.
Yeah.
Okay, wait a minute. Let me get into my Zoom.
All right. Let me try this now.
Okay.
Okay. Now can you see the second slide?
Yeah, yeah.
Okay.
Okay. Whew, thanks. Okay.
Sorry.
I'll just speak very fast. So, I think the issue, we all know the biopsychosocial model is sort of the model to treat chronic pain and that means education and how do you explain what the biopsychosocial model means to kids and families? My foot hurts. What's this biopsychosocial model? And okay. And social support. How does connecting with others help my foot pain? And this concept of how do you use your creative brain to reduce suffering? And I'm going to talk about the use of metaphors and to the lay public, neurobiology descriptors. And then, the bottom line is this idea of whole body. When it's my right foot that hurts, fix my right foot. Next slide. Right. So this is probably old already. And this was a study done just in the United States. And, we know that the cost of chronic pain for families above what insurance pays is enormous. And there are good data to show, and I have references for all of this, if anybody's interested. 34% are less likely to graduate from high school if they have ongoing chronic pain. 17% are less likely to achieve a college degree. 20% are less likely to receive employer-provided insurance, pre-existing conditions, and 13% are less likely to find employment related to what their long-term career goals are. Next. So we know that, let me just move this. We know that kids with chronic pain have mental health needs, and we often don't know what came first: anxiety, depression, pain. We do know that they have feelings of sadness, feelings of uncertainty about ever getting better. They feel isolated, lonely, and just loss of self-agent, loss of self-confidence. And the sad thing is that so many kids are brought to different body-focused subspecialists who do evaluations, they try treatments, but the kids continue with chronic pain. So often by the time they go to a pain clinic, they've seen 30 doctors and they don't believe that you're going to do anything more than anybody else did, which is not help them. Next slide. So why are pain and adolescent mental health so intimately linked? Well, first of all, we know frontal lobe is still developing, the new brain. So adolescents are impulsive, they may have poor judgment. There's significant peer influence, which also means peers are important. So a lot of peer-related stressors, issues. In middle school, the Mean Girls group starts. And we know that from neurobiology, there are connections between pain neural circuits and parts of the brain related to fear, memory, perception, emotions. And the way I describe this to families is there's too much traffic going on, and there's no frontal lobe traffic control to sort of organize the traffic. Next slide. So what are the vulnerability factors? And people who treat kids with chronic pain see this all the time. So neurodiverse brain development. And there are a lot of kids that haven't had an ADIS to diagnose autism spectrum disorder, but clinically, there are a lot of pieces of autism that create problems for the kid with chronic pain. Kids with ADD and ADHD, kids with learning difficulties. And a lot of these kids, others too, are sort of have a history of school bullying and isolation. And then we all know about ACEs, past history of multiple traumas. These are all vulnerability factors, past history of pain events, fractures, sprains, minor athletic injuries, past surgeries. All of these, are there in past memory. And then there may be a setting event that then leads to CRPS or headaches or some. And certainly um, Bonnie Stevens, Ruth Grunow, I mean, it was the Canadian group that taught us about premature birth and time spent in the NICU. You know, clinically, there's delayed pruning of dendrites and a high acute pain exposure. And then family factors, if there's significant past and ongoing trauma, and then other things like moves, a new school, other significant life changes. Next slide. So this is what I call sticky neural loop. And certainly kids on the spectrum, one of the characteristics is perseveration. And I call it a sticky neural loop. And that could be the pain. I have a headache, I have a headache, I have a headache. It's, you know, beliefs, thoughts, behaviors, and the pain symptoms themselves can become an OCD. And you have kids with regurgitation, for example, treated uh, by GI, by respiratory medicine, etc. Um, we know from the work at Laura Simon and others about expectation and pain fears. You know, if I go to school, I know I'm going to have abdominal pain and then I'm going to have to get to a bathroom and my stomach is hurting and I can't anyway. Um, this expectation of pain. And then patterns develop, pain avoidance patterns. So school absenteeism, peer avoidance, sedentary behavior. Kids hang out in their room and they don't come out. And for many kids, they just have difficulty with transitions and a change in daily routines. And I have some kids who are on the spectrum who are doing great at school. They get a prolonged Christmas, winter break, and then they have trouble going back to school. And the cycle begins. Next slide. And what about the parent role on disability reinforcement? We know parent can focus on their child's pain, you know, well-meaning, but how is your headache? Can you give me pain ratings? And a lot of kids will come in with, well, my pain is usually at an 8. Sometimes it goes to an 8.2. But anyway, it's like in order for a kid to give a rating, or tell parent about their pain, their brain has to go to the site that experiences that pain in order to give it a rating, and it reinforces it. Um, and then parents often don't know how to deal with a teenager's pain behavior. Kid refuses to go to school. Parents don't know what to do. Do they push them? Do they not? Do they keep bringing them to more doctors? And then we know parents may be going through their own stressors, parent couple difficulties. There may be another child with problems, same or different. Next. Um, so we, when you talk about pain to a kid and parent, you have to talk about it in a way that makes sense. They need buy-in. And so I use sort of lay neurobiologic reasons for the chronic pain, how it likely started, what are the things that evolved and are contributing to it, what keeps it going, what makes it worse, because those are all things you need to tackle with the family. And the bottom line is, I say, for whatever reason, your entire nervous system is out of balance, out of whack. Um, and then I also talk about how factors developing before or after initiation of pain will continue and worsen the pain. And so they do need to be addressed. So whether there's anxiety, depression, difficulty sleeping, these are all have been well-researched poor eating habits that can lead to what's now called ORFID, weight loss and cachexia, because the kids started out with irritable bowel syndrome and afraid to eat, and pretty soon is not eating and losing weight, sedentary behavior, learning difficulties. All of these can be factors that need to be teased out and addressed. Next. So, what are the goals of treatment? So, I talk to families about your kid's system is out of balance, and the goal of treatment is to rebalance the body's nervous system. And it's top down and bottom up. And oops, not yet. And the top down can be different types of psychotherapy as needed, and it can also include mindfulness and hypnotherapy. And the bottom up can be PT, yoga, graded rehab exercises, but moving the body is important. Next slide. Yep, there we go. And the important thing is meds alone are never the answer. Rarely. And at least the kids I see, they're not the answer. They've already been on gazillion meds. And procedures may be useful, but often they do not provide long-lasting relief without other changes. And that psych and sleep meds in some cases may be helpful, but they shouldn't be the only treatment. Again, meds alone are not the answer, or procedures alone. And a goal for most teens, and not all, is to return to school. And we know that re-engagement with peers is important for kids who have spectrum-y neurobiology, but many of these kids need to learn how to do this effectively. And this was brought up. We always say function typically precedes pain reduction. Watch the lips, not the feet. Now, watch the feet, not the lips. See what they're doing, even though they're still complaining about just as much pain, but they're doing a lot more. And Chuck Birdie brought up in Glasgow, is that really our goal? Just having them function but still be suffering? And it's an interesting question, because we always say function, doing more will precede before you, rather than in acute pain, you want to get rid of the pain first. Next slide. And uh, Alex Neville, working with Melanie Knoll, and now she's at Stanford, she did a lot of study on who are these parents that do doctor shopping. And what she found was parents who have difficulty with uncertainty are typically the parents who bring their child to multiple specialists, and who are the ones who respond to online treatment miracles advertising. There's a whole marketing industry of all these places and doctors and chiropractors around the world that, and certainly in North America and more in the US, because people are paying out of pocket enormous amounts, if they can afford it, to see these doctors that have testimonials about miracle cures. And so, as you're working with a family, how the pain and plan of treatment are explained are critical. You need buy-in for them to want to stay with it and follow through. Next slide. So many, and many of you have seen this, many parents are hoping for a diagnosis and a medical or surgical treatment to fix it. It's okay, this is the cause by my kid's knee, and we'll do this surgery or we'll do this injection or this medicine and that'll fix it, and physical therapy and this, and that's it. And a lot of times that's not the answer. And what's interesting, and I don't know if others of you seen kids with chronic pain, there are many parents and teens feel better with multiple diagnoses. So they'll be all excited. They went to a POTS clinic, and there's a big POTS clinic at UCLA, and now they have POTS. Well, in the office, I did a sitting and standing blood pressure and heart rate, and the pulse went up 30 beats per second with going from sitting to standing, and they have POTS. And most kids, when their whole body's dysregulated, have POTS, but they go to a POTS clinic, get a diagnosis, are told, a lot of salt, a lot of water, and maybe wear support stockings or tights. So EDS is the other big thing. Ehlers-Danlos, hypermobile Ehlers-Danlos syndrome, and that is kids who are very flexible, even if they haven't had any dislocations, have H, little h, big EDS.
عمر روح هناك روح هناك.
Can you just
You guys
mute?
mute, please.
Yeah. Let's go back again. One more slide. So this idea, kids,
I'll try to mute. I'll see if I can.
thank you. Kids try to, that parents feel better, not all, with they have POTS, EDS, chronic fatigue syndrome, post-COVID syndrome, the idea of accumulating diagnoses rather than just chronic pain. And so it's important that the subspecialty physician or primary physician needs to explain also how psychotherapy actually treats the pain through brain neural pathways. And, a lot of families who are not psychotherapy exposed will just have a hard time understand how just talking with someone helps foot pain. So that really needs to be discussed. Next slide. So I created and brought in a lot of other great people, a nonprofit, and we renamed, ages ago, but we renamed it when I retired, Creative Healing for Youth in Pain, or CHIP, CHYP. And that's the website. And what I wanted was something that wasn't treating pain, because there are tons of good programs increasingly, and ChildKind is really increasing the amount of good pain treatment at hospitals and programs. But I wanted to provide a free online nonprofit for teens and young adults, that transition age group, 13 to 25 years, for youth with chronic pain and for their parents or caregivers. And I wanted to provide state of the science education about chronic pain. And a lot of times we'll refer to ChildKind references in the library and other programs that have great references. But it's one place where they can find education, the kids and the parents. I wanted to have a program of basic self-help skills for teens, and programs on parenting the kid who has chronic pain, giving, again, education, social support for youth and for the parents, caregivers, and then creative arts programs for youth, including summer camp. Next slide. So I'm going to go into some of those. And I talk about the creative arts workshops as changing brain neural circuits, reducing pain, enhancing function through creative programs, art, writing, music, movement. And there's research behind all of the programs that we provide. And then we have a summer creative self-help skills free camp that's all online. And it's actually international. We've had kids from England and Ireland. We're trying to increase the number of camps so that the times can be more conducive to maybe two camps in different parts of the country. Yep, next slide. So we talk about creative healing or setting up new pathways by using your brain in creative ways. And we actually have some, they're not just us, but functional MRI, seeing new pathways in kids that are doing meditation and kids that are doing yoga. We did a number of yoga studies, and other people have looked with more modern technology at how these factors, these creative arts, actually change brain neural pathways. Next slide. And so CHIP is an online community for teens, young adults living with chronic pain, and for their parents. And the whole idea is that we want to facilitate healing through pain education, peer connection, and online group creative arts. Very simple, three main goals. Next slide. So for teens, we have a number of programs for teens, youth chit chats, and it's guided by a postdoc psychologist or and psych intern, and one or more, and they've gone through training, and we have a backup system if needed. And it's a monthly drop-in teen support. And there's a lot of social media goes out saying when the meeting is and how to get in. And obviously we want to be able to do more of that. We also have a self-help tools course. It's recorded. You can download the sort of the lessons learned, and it's 6 sessions at your own pace. And then a lot of kids talk about it at the chip chat. We have the resource library, films, articles, dialogues about pain. A lot of kids have contributed to that. And in our resource library, we refer to other programs like ChildKind and Rachel Coakley's program and other programs. Creative arts workshops, we get chefs, we get musicians, we get actors, we get writers, artists doing these programs that are workshops, and then our summer camp, creative arts, and some self-help skills. Next slide. And parents, we have programs for parents and caregivers. We have a monthly parent chit chat. And again, it's drop-in parent support. And that's run by Dr. Samantha Levy, but we're going to have more of those because that's been growing. Our Creating Bonds, it's an 8-week, we'll probably enlarge that session on parenting the teen who has chronic pain. People sign up and we keep it small for 8 to 10 parents so that they can form a bond with each other. And Dr. Levy really goes through working with them on dealing with issues related to having a kid who has chronic pain. And then we have weekly blogs, topics relevant to youth with chronic pain, anxiety, depression, POTS, OCD, eating disorders, fatigue. And we also have teens, young adults who are 19, 20, who have been involved with CHIP, writing from the teen perspective or the young adult perspective, blogs, and some of the parents are writing blogs also to support others. Next, and we're almost done. And then we have monthly webinars with national, international experts. And I think Neil has done one, Bill has done one. I call on my colleagues nationally to have this discussion. It's 1 hour, it's filmed, it's online. People sign up so they can ask questions. I used to be moderator. Now I'm getting others to do moderating, and it's Q&A format. It's not a lecture. And then we have our resource library for parents. Next. And we have a lot of YouTube videos for parenting. And we're going to be doing some workshops for the parents to help them using hypnotherapy, mindfulness, exercise. I think the next slide should be the last one. Yep. So at this point, I'm done. And take it over, Bill and Neil.
Thank you, Lonnie. That was wonderful, and it's so impressive to see the development of your program. And I think this has been a gap in the pain world. Is really services for families. We're starting to develop more of this, certainly. And I was curious, just as others, feel free to put your questions in the chat. Is there opportunity? Because one of the areas that I think we've shortchanged our families on is helping kids with chronic pain interact with other kids with chronic pain, and acknowledging that your program is virtual. Are there ways that you found to encourage that development of relationships between these kids?
Yeah. First of all, I have to say I don't go on because some of them are my patients. So, but when you have a kid from the middle of rural Kentucky talking with a kid from Beverly Hills in a very well-endowed family, and they find they have so much in common and they start supporting each other. I mean, it's crosstalk to find the commonality of how kids give to others and they support each other. And that was the idea, to have kids. We have kids from England and Ireland who have been camp counselors for our CHIP camp. And Rachel Coakley and I communicate. So some of her people, we did some combined team meetings with her group and our group, because her group tends to be people from the East Coast for the most part. At least when we started, it was West Coast, but now it's all over. And we just hired a new fabulous executive director. And we have this big fundraiser in October at UCLA for our 20th year. But the idea is we want it to be free. So, insurance, economics is not a barrier. And we want kids from different forms of life to meet each other. I mean, and there's a commonality. We want to be something that we're not treating pain. I mean, that's the individual treatment or in the pain clinics, but we want to provide all the other stuff in one place and make use of connecting what's out there in terms of resources and give credit to that. And we do some combined programs. So it's like and it's all free. It's like how to spread the word among all the kids and all the programs. I mean, our advisory board, which now we will be getting advice from, is, it's a who's who in chronic pain in Canada and the US and England, but we'll be enlarging that. Everything we have that's not live at this point is translatable in 12 languages. So if you're in, we even have Canadian French. So the idea that parents who only speak a different language can participate, as we bring in more income, because we don't want to charge anybody, we could do a whole lot more, and we want to pay, the chip chat, for example, and the creating bonds program. I could see going to, your postdocs and your grad students in the different programs where they've already been trained on chronic pain, and pay them. We don't pay a lot, but pay them to do a monthly 1 hour chip chat, but maybe do it on a weekend or do it on the East Coast at a time that's easier for Nova Scotia or, so I my goal is to make this useful for our broad international pain community and do what I can, use my contacts with everybody to do this. And our evaluations are fabulous. And I want to use it as a research resource also. We've done some research with other groups we've published. It's a biased population, so it has to be a certain kind of research. But and my other goal is to have unique sub-programs for certain populations. I've been working with the group Tim Oberlander and group in Minnesota for kids with CP and, kids with sickle cell disease, and add to what is, not to replace, and for parents, different subpopulation, kids with cancer, kids, anyway, name it. So, but that's my goal in growth, and I'm going to be quiet.
Well, anybody who has a question, feel free to put it in the chat, or I'll just keep peppering Lonnie with different questions. But I guess the next thing, Lonnie, and you didn't mention this group, so I'm going to ask, at some recent meetings and also our own experiences, our kids are getting older. So we have a lot of kids in that 18 to even 25-year-old age group who, frankly, there are not a lot of great programs that fit their needs. And I'm curious, is that an area where you think there's opportunity and you might want to expand into as well?
Absolutely. And that's why we made it. I mean, cybersecurity, we started at 13, and there are 13-year-olds functioning like 9-year-olds, and there are 9-year-olds functioning like 13. So somebody younger, 10, 11, can, if there's a written permission from the parents, they can participate. But I wanted to go to age 25 because I wanted that transitions age group. I mean, as you know, and I've been seeing over the years, a lot of kids with sickle cell disease moving to that transition from the nice warm fuzzy of the children's hospital program to adult care, other than in certain places. It's like a whole nother world. And I think for a lot of kids, going to pediatric pain clinic, and then suddenly you're too old for the children's hospital, so they can't, the pain clinic isn't allowed. I mean, at UCLA, I wasn't in palliative care. On the inpatient, I could see kids that were a little older, but in pain clinic, 18, at 17, before 18, I could see them once they turned 18, they had to go to the adult program, which was very anesthesia procedure focused and not coordinated like peds pain clinics are.
Great. Thanks, Lonnie. So again, any questions, please put them in the chat because otherwise I'm going to have to start I'm going to have to start either calling on people or start asking hard questions. So while I'm waiting, I am going to ask a hard question because you brought this up, Lonnie, and it's a little off the track of this particular webinar, but you brought up this issue of, what is, I guess, cure or remission and pediatric pain. And this, as you know, was brought up because I was in that session too.
Yeah.
It was a session on CRPS, and there was discussion whether, you have a child who's has CRPS, who's fully functional, but still has pain every day or all the time. Is that cure? Is that remission? And I think it was a very controversial discussion, frankly.
Right.
And I'm curious what your thoughts are, and I'd love to hear from people in the audience about this because this is something that I think we wrestle with. We're focused on function, but we also have to acknowledge there is a shortcoming to that at the end of the day.
I want to say, and I want to hear from the audience, but there are some in LA, and I don't know how common this is, there are some adult pain specialists in practice, not at the university, who tell patients they'll see kids, even though they're not trained to see kids. And they're very procedure focused. And they will tell kids that some of them suggest that if they ever get pregnant, that could exacerbate if they still have CRPS or make it worse, or if they have any surgery, or they sort of suggest that this is with you for life, which is, really, it's setting a very negative pathway. And what I see longitudinally is some kids initially learn to live with it. And they, the idea of function precedes pain, but the pain begins to bother them less. It's there. They say it's there, but there's it's almost, like ACT acceptance therapy. Yeah, it's there. Maybe it's part of me, but I'm not letting it run my life. And what happens if you follow these kids, and I've seen many kids long time, the pain eventually goes away or it gets really minimal. Something might have it come back, but they know what it is, they know what to do, and then they can bring it again to the background. I'm curious about other people's ideas.
Yeah. Samantha, do you want to comment? Samantha Levy wrote in the comments, one of them, with most of the kids I see, once they're fully functioning, get involved in other activities, the pain eventually fades away or mostly does. Anything?
Yeah,
Go ahead,
I think that's kind of what we're talking about with CHIP is that shedding the identity of a patient, shedding the identity of someone with pain, which becomes sort of their full identity when they're in the thick of it, and then they start to do something else, and that replaces their identity. A good example is our patient who had CRPS in her arm, and then after she got intensive treatment, she suddenly got involved in color guard, which is twirling these large poles with your arm. And she got so involved in it that became her identity then, someone who does color guard instead of someone who has CRPS. And then eventually the pain just sort of faded away. And it's there very mildly, but like Lonnie's saying, she's barely noticing it.
Thank you. Anybody else want to comment?
Yeah, I'll chime in for a second. This is Neil Schechter. In my experience, it's sort of a mixed bag about this over time. And it seems like to me, if the pain is the result of an acute episode, if you will, and doesn't end up being multiple pain problems simultaneously, or if there's not a pre-existing anxiety and depression that's a part of the picture, those kids you tend to struggle with those a little bit more, and the pain can recur. Kids who had sort of more an acute injury, if you will, that ended up in CRPS, and it doesn't seem to take over their life or become their identity. Those kids, it seems, there's different trajectories. It feels like there's a sort of a different quality to that recovery. So it does feel like they can put it aside, and even though it may recur, they have the sense that it will disappear as it had before, or it's just could put it on the back burner. So I think the mental health piece of this complicates outcomes and trajectories.
Thanks, Neil. Other comments, questions?
I think there are, also thinking about being psychodynamically oriented, sort of the meaning of the pain. I mean, in terms of location, I had a kid who was this great kid, super smart. His father was the wrestling coach for his high school team. He was a wrestling star. And suddenly he developed chest pain, not, functional chest pain. I mean, he had seen, you know, his doc and the specialist and the orthopedist and the neurologist and so it got in the way of wrestling. And yet he loved wrestling and he was very good at it. So you have to think about what, what is behind sort of the, not consciously, but the meaning of the location. So he did fine with just psychotherapy, talking about some of his anxieties about disappointing his dad and expectations, etc. And he had physical therapy to strengthen a lot of because then he had stopped wrestling. And then he got back to school and he's wrestling. And he's, it was a CRPS focal because he had allodynia, hyperpathia in that area. And it went away and he's functioning back to wrestling. Somebody had
Well, there's let's see. Fadi, real impressed with the great initiative, Lonnie, involving caregivers. Any thoughts on the value and how to involve siblings?
yeah, siblings are a forgotten group. And some of the kids I see later on are younger siblings of kids with chronic pain that absorbed a lot of attention. And as they got older, it's almost like it was their turn. And so I do think siblings in many families suffer. And certainly with CHIP, as we raise more money, we would love to have programs for siblings so that I don't want to say they do because it's not conscious that they don't have to develop chronic pain in order to get the attention their sibling did, but the idea that they're missing something or there's they need attention. So that's
I'm proud to say two of our nurses at our program, Carol Ortega and Kim Harris Eaton, are developing a research project around siblings of kids with chronic pain. So stay tuned. Maybe I'll have them present that someday in the future. So
would be great.
all right. Oh, wait. Oh, he said thank you. Now the questions come flying in.
Yeah.
Waleed says, does the pain truly decrease or does cognitive distraction play a primary role in pain perception? Is there a risk of emotional suppression if pain is overshadowed by a stay active approach?
That's a really good question. And a lot of people think it's distraction that really is the answer. And if you can get kids to do things and distract from their pain, we did a study in the dinosaur days looking at kids, and this is Renee Manwarin's area, but acute pain, kids getting before they would give propofol, kids with cancer who got LPs and bone marrows, and they got LPs every, I don't know, once a month. And so we randomized to treatment as usual, to distraction, and to hypnosis. And the hypnosis group did far better than the others. The distraction group did better than the usual care. So distraction plays a role, but I think there's something more than that, than just distraction.
Great. And then Waleed had a follow-up question. What role does psychological resilience play in how children will cope with or overcome pain?
Yeah, I mean, we're easy to, as researchers, to study pathology and problems. We're less likely to study resilience. And I think there are a number of increasing studies in other areas on resilience. And, you have kids that grow up with gazillion aces, and yet they are stellar in their emotional well-being and function. I mean, what leads to resilience? And some of the research suggests having a significant other doesn't have to be in the family. It might be a peer or a teacher or a coach, but having somebody else who believes in you and values you is one of the factors. And we see kids that are resilient. And that's the whole benefit of CHIP, that kids who are resilient give guidance to kids who are less resilient.
Great. Thanks, Lonnie. And I'm just going to answer the last question just in the interest of time. They asked about, we will be sharing the presentation. It will be available on our website. The question involves, which of the great programs that are out there, including yours, Comfortability, our own ChildKind program, should centers look to implement? And I think I think you should look at all these programs are different, have different resources. Certainly, Lonnie's program is very focused on the family and the child from a kind of wraparound, whole supportive nature. Comfortability has those resources, but it's also very focused on a specific intervention, and there is a cost associated with getting that program up. Where Lonnie's program for the institution or the family, there's not a cost, so we consider that. And then ChildKind is very different. It's really an helping it's really an institutionally focused program, helping institutions look at their pain program, evaluate it, and then with the certain principles that we employ, really hopefully provide a diverse and effective pain treatments for children. So they're all a little different. I encourage you to look at all of those, and there are certainly others, Skip in Canada, et cetera. So, certainly you can reach out to Meredith or Lonnie or Rachel Coakley for more specific information about those programs. All righty, but I really appreciate everybody for joining today. Lonnie, that was fabulous. And as the last commenter said, your work is incredibly inspiring, and I entirely agree. So thank you, everyone, and we'll see you in the fall.
Yeah, thank you.
Great. Thank you so much, Lonnie.
Bye. Thank you.
Bye.